So, in our talk about the Galeazzi fracture dislocation, we will start with an introduction. So, Galeazzi fracture is a fracture of the middle to distal radius, and it is associated with a subluxation or dislocation of the distal radioulnar joint. So, it is a radius fracture with a distal radioulnar joint injury. And Galeazzi fractures are much more common than Monteggia fractures. Galeazzis account for 7% of all forearm fractures in adults. Now, it is important to know that in Galeazzi fractures, the radius fractures occurring closer to the wrist are associated with a greater instability of the distal radioulnar joint. So, the closer the radius fracture from the wrist, the higher the instability of the distal radioulnar joint. Now let's talk about the mechanism of injury of Galeazzi fractures. So, they are caused by a fall on the outstretched hand with extended wrist and pronated forearm and a rotational force applied to the body. And Galeazzis also occur from sports injuries and motor vehicle accidents. Now moving on to talk about the clinical features of a patient presenting with a Galeazzi fracture. So the symptoms include that the patient present with a pain in the forearm and the wrist. The forearm pain indicates a radius fracture, and the wrist pain indicates a distal radioulnar joint injury. Now regarding the physical examination, so the physical examination follows the pattern of look, feel, and move. On looking, you look for swelling. There is normally a swelling around the forearm and around the wrist, and there might be contusions and lacerations, and there might be deformity of the radius or wrist that might be obvious, and you inspect the lacerations looking for any evidence of open fractures. Now regarding the feel, so you feel for tenderness over the forearm and the wrist, and you do a neurovascular examination to look for nerve and vessel injury. And in case of the Galeazzi fractures, the median and radial nerves are the most common to get injured. And you inquire about weakness, numbness, paresthesia, and motor examination to make sure that there is no nerve injuries, and you palpate the radial and ulnar arteries looking for pulse, making sure that those arteries did not sustain injury. Now regarding the move, so you ask the patient to move their limb, but they refuse because of pain. And examination is repeated multiple times to exclude compartment syndrome. Now there is a good risk for compartment syndrome with forearm injuries. That's why we always examine and repeat examination looking for compartment syndrome in all the forearm injuries and fractures. Now after you finish taking history and examination of the patient, now you move on to do imaging for the patient. So you order X-ray radiographs, and those include the forearm, anterior-posterior, and lateral views, and they should include the wrist joint, and usually a transverse or an oblique fracture is seen in the radius with angulation or shortening. So as you can see on this picture here, we have an AP and a lateral forearm x-rays, and we can see that we have a radius fracture here, and it is also obvious on the lateral view, and we can see that the fracture is an oblique fracture and it is angulated. We can see that the apex of the angle is pointing posteriorly. And also on the x-rays, we should look for the distal radioulnar joint injury, and when the distal radioulnar joint is disrupted, there is signs to look for on the x-rays, and those include widening of the distal radioulnar joint, and they may also include dorsal displacement of the ulna on the lateral view. Other signs include ulnar styloid fracture and a radial shortening greater than 5 millimeters. Now, if you find any of these signs on the x-ray, then this would confirm a distal radioulnar joint injury. And on this x-ray here, we can see some signs of distal radioulnar joint injury. We can see that the joint is widened. That is because the ulna is a little bit displaced, so it means that there is injury to the distal radioulnar joint. And we can also see that there is dorsal displacement of the ulna on the lateral view. So this is here is the ulnar head, and we can see that it is dorsally displaced, meaning that the first and the second signs are obvious on this x-ray, and this means that we have a distal radioulnar joint injury. Now, a quick note to look for is that the distal radioulnar joint is injured with the Galeazzi fractures, but it also could be injured with isolated radius fractures at any level or in both forearm bones fractures. Now, moving on to talk about the management. So first, let's talk about the emergency management. So the emergency management include the pain control, and also in the emergency department, the gross forearm deformity should be reduced in the emergency department under procedural sedation, and above elbow back slab is applied to support the fracture and prevent rotation until definitive treatment is done, and reassessment of the neurovascular status is done to make sure that there is no neurovascular injuries occurred during the reduction or during applying the elbow back slab. Now, after the emergency management comes the definitive management. So in the definitive management of Galeazzi fractures, it is the same as the Montagias. It is important to restore the length of the broken bone. Now in Montagia, we restore the length of the ulna because it is the broken bone in Montagias, but with Galeazzi's, we restore the length of the radius. Now in children, close reduction is often successful, but in adults, close reduction lead to poor outcomes. That is why in adults, reduction is best achieved by open reduction, internal fixation, and depleting of the radius to restore its length, and the distal radioulnar joint is re-examined and re-imaged to ensure it is reduced. Now after we plate the radius, now we check the druge. So if the distal radioulnar joint is reduced and stable on full range of movement after we plated the radius, now no further management is needed. But if we plated the radius and we restored it to its normal length, and we checked the druge and we found out that it is reduced but it is unstable, So when we try to do the full range of motion of the wrist, we find out that the druge is dislocating with the full range of motion, then it is considered unstable and the forearm should be immobilized in the position of the stability for the druge. And the position of the stability is usually supination, and the K-wires may be applied to support the joint. Now the third possibility is that if we restore the radius to its full length and the druge is irreducible, meaning the distal radioulnar joint didn't reduce on its own, and we try to reduce it, but it did not reduce, meaning it is irreducible by close reduction, then open reduction of the druge is needed to remove soft tissue interposition or fracture fragments, preventing reduction. And with open reduction of the druge, this means that the triangular fibrocartilage complex and the dorsal capsule of the druge are then carefully repaired, and if there is associated ulnar styloid fracture, then it has to be repaired by open reduction, internal fixation. Now, after reduction, in all cases, meaning after reduction in all of the options mentioned before, the above elbow casting in supination is done for 6 weeks, and exercises started as soon as possible to prevent stiffness. Finally, let's talk about the complications. So complications of Galeazzi fractures include early and late complications. Early complications include vascular injury, and in vascular injury we have the radial and ulnar arteries. Those can be injured and they should be repaired. And we also have nerve injuries, and we mentioned that the radial and the median nerves are the most to get injured in Galeazzi fractures. And in the early complications we also have compartment syndrome. Compartment syndrome occur when the pressure inside the muscle compartments gets increased, and the pressure getting increased leads to impairment of the vascular supply to the muscles, and this would end up with muscle necrosis, and it may lead to amputation of the limb. The pressure buildup inside the muscle compartment is coming from the muscle swelling that occur from the muscle injury. So when the muscle gets injured, it swells, and this would lead to increase in the pressure inside the muscle compartments, and it would end up in the compartment syndrome. And muscle injury is much more when there is a high energy injuries, and that is why compartment syndrome is especially associated with high energy injuries. In early complications, we also have muscle tendon entrapment, and this would lead to reduction being difficult. In late complications, we have malunion. Malunion is fracture healing in abnormal position, and we may also have non-union. This means that the fracture would not unite, and we may have radioulnar synostosis. Radioulnar synostosis is abnormal connections between the radius and ulna, and the final complication is elbow stiffness. Elbow stiffness risk highly increased if the immobilization is prolonged. And with that, we reach the end of this video. Thank you guys for watching. Please give us a like and comment your ideas and questions. And this video is a part of a bigger class. It is called the Elbow and Forearm Trauma Masterclass. You can check it out. Link will be in the description of this video. Thank you for watching, and peace.